All right. So, we are going to study some diseases affecting the eye today. There is a small change in the normal program. So we must be familiar with the anatomical structures concerning the eye so that we can understand at which part of the eye each disease focuses. All right? So have a look here. It is very important, first of all, to see the three layers of the eye. Have you done eye in your anatomy classes? Good. So if I'm not so good at anatomy, you'll help me. All right? So you see here that we have the retina, the choroid, and the sclera. When the sclera comes out, we have the cornea. And here we have the anterior chamber, which is the margin, you see here, is the iris. And here is the pupil. We have the lens, and here is the anterior chamber filled with aqueous humor and probably affected by a very severe disease when there is an increase in the pressure, which is glaucoma. Then we have a look at the posterior chamber, and here is the vitreous body with the vitreous humor. Again, we can see the structures, the conjunctiva up in the iris, the lens, the cornea, which goes then here to the sclera, the retina, here is the macula, and here is where the nerve comes out, all right? This is a part of the retina which we can examine when we look at the fundus of the eye, because if this area is a bit swollen, this might be related to an increase in the intracranial pressure. So this patient needs investigation. What has increased the pressure in the brain? And here we see the two chambers again, anterior and posterior, the cornea and the uvea, which is composed of the iris, the ciliary body, and the choroid layer. So here is again the optic nerve with the optic disc, which is part of the retina. So this is the basic anatomy. Now, we have a very young boy, 5 years old, with a 1-year history of deteriorating vision in his right eye. We see that the pupil is white. Why? Because there is something growing behind, and you see this whitish tumor here. You see? So we don't have the typical retinal red reflex, because when you have a look at the fundus of the eye, it appears red. The retina appears red. Here we cannot see that because a tumor has grown. And where is the tumor? Which is this part that the tumor has occupied in conjunction with the vitreous body? You remember which chamber is this? The posterior. Excellent. Yes. Well done. So this is the enucleated eye. The eye was surgically resected, and we make a cut through the eye and we see the tumor. So this is a very large intraocular tumor which extends into the vitreous of the posterior chamber. It is a retinoblastoma. It has grown there, that's why the pupil is white. So this is a tumor which is a very good example of the inactivation of a tumor suppressor gene. This is the respective gene, retinoblastoma gene. You all have heard of it in the lessons of neoplasia. And since this tumor appears at a very young age, when tumors appear in young patients, what do we think clinically about these patients when we have a cancer in a very young patient? It could be either congenital or inherited. And this justifies this case here because this boy was born with a germline mutation in the retinoblastoma gene, so that the whole gene, because this is an oncosuppressor gene, for the whole gene to be inactivated, we must have the two alleles having a problem. One is already by its birth the problem. So in short time, another mutation occurs in the other allele. So both alleles of the tumor suppressor gene are inactivated, and that's why the tumor grows. Histologically, it is a tumor composed of small round blue cells. Do you have any idea from our neoplasia lessons which tumor appear like this? Now it's a young boy, so of course we think of a retinoblastoma, but this general category of small blue round cell tumors has also, any idea of some tumors who have cells very dark, meaning that they don't have enough cytoplasm? That's why they are dark. Can you think of some other tumors we have already encountered in our program that have small cells, dark staining cells? Which tumors do you know?
Is it cervical cancer?
Yes, but the cells should be eosinophilic because squamous cells are not blue. They have cytoplasm. They have eosinophilic cytoplasms. So it's not probable. It's not impossible, because sometimes in the cervix there is a blue tumor which, when it is carcinoma, this is a neuroendocrine carcinoma, such as the small cell carcinoma it's a carcinoma with neuroendocrine differentiation composed of small blue dark cells. So one category is small cell carcinoma. Another category that you have recently studied, a lymphoma, of course, because lymphocytes are small cells if they are mature. If we have a lymphoma of mature lymphocytes, they would appear like blue round cells tumor. The other tumors are mesenchymal tumors, such as primitive neuroectodermal tumors, known as PNET, with the most common representative being the Ewing sarcoma. And there are also some other tumors in head and neck, the olfactory neuroblastoma. Among all these tumors is the retinoblastoma. So, where should you expect metastasis? The brain and the bone marrow. That means that this tumor spreads with what route? Via vessels, all right? Via the blood. Okay. Here, another tumor. Have a look. In some areas, you can see that it has this color. How would you describe this color? It's black. It's black. Because some of its cells are adequately differentiated and they have such a black pigment in their cytoplasm. So, what could this be? Appearing like focally. All right, focal. It could be a melanoma because melanocytes have melanin, and melanin stains black, and it stains in the tissue sections. When we find this with a specific histochemical stain, namely Masson-Fontana stain, it highlights melanin pigment, but sometimes they appear black because they are composed of melanocytes. This is not a prerequisite for the diagnosis of a melanoma, because all melanomas are not composed of differentiated melanocytes so that they contain pigment. Some of them are primitive melanocytes, and being primitive, they do not have pigment in their cytoplasm. So it's not necessary to see melanin so as to diagnose a melanoma. Now, when it has, here is a middle-aged man with a 1-year history of deteriorating vision in one eye, and suddenly he lost all vision from that eye. And here is the enucleated eye after surgery. You see here how the vitreous body is compressed. It nearly fills the posterior chamber. It nearly fills the posterior chamber. We discussed this color and its significance for the diagnosis. And most typically, it arises in the uvea. You want me to go back and see what the uvea is and the structures that it is composed of? Shall we go back? Because I'm not very good at the eye anatomy, so I have to go back and see the structures. So this is the uvea. This is the area where most melanomas grow. What is it composed of? The iris, the ciliary body, and the choroid. Mostly the iris, because when I had an eye exam, the ophthalmologist told me that I had a nevus in the iris. And a nevus, a melanocytic nevus, is the benign counterpart of the melanoma. So I should be examined on a regular basis, because if you have a benign neoplasm composed of melanocytes, you have to check it. If it grows, if it changes size, contour, because all these are signs of possible malignant transformation. And when you have a benign nevocellular melanocytic nevus, it can transform to a melanoma. All right? Yes, please. On the macroscopic level, as far as the eye is concerned, there are not definite signs of malignancy. But when you see such a big growing tumor, even though it is not clearly invasive as a malignant tumor, it's possibly malignant because it has grown too much and has caused very much trouble. Of course, we said that malignant tumors have atypia on a microscopic level and invasiveness. These are basic features of malignancy, but they are not pathognomonic. That means you can have a tumor which is well circumscribed, however, it could be malignant. But the rule is not that. Yes, please.
Why do they typically arise in the uvea and not elsewhere?
Probably there are some cells, since the iris has color, there are probably some cells containing melanin. I'm not sure, I have to check it in histology. But it could be an explanation because there are colored cells. And there is another sort of pigment in the eye. It is a part of the retina when we have an epithelium which has stains. It has some granules in it. We'll see it later. All right? So that was the melanoma, and all melanomas spread via blood vessels, and the most common site affected is the liver. So if you have a liver metastasis and you see the metastatic lesion to be a melanoma, you have to find where the primary is. One of the sites that you have to check is the eye. Of course, you look at the skin and see if there are some nevi which appear suspicious for melanoma, but if you don't find anything, don't forget, look in the eye.
Why is it the liver though? Why the liver?
The liver takes hematogenous metastasis from all malignancies. Probably it's not just a matter of blood supply, because the spleen also receives it has increased blood supply. However, metastases in the spleen are very rare. So what makes all malignant cells go to the liver and grow there as metastasis? Possibly there must be some features of the liver microenvironment which facilitate the growth of metastatic cells.
But
Okay?
I mean, the previous case we saw, it's like the brain and the bone marrow.
Yes, this is called the metastasis tropism. That means taking into account what tumor you have, there is a possibility that some organs will be more probably secondarily invaded than others.
Thank you.
Okay? So that was the melanoma, and what caused the loss of the eye? With the tumor growing, we have a detachment of the retina. So this is a very serious problem. Here it is a rare cause of retinal detachment. It's not so common for a tumor to cause this. However, this is a surgical emergency, because if you have a retinal detachment, then means that you have very little time to fix what went wrong and get the retina again attached to the base of the eye, because it's what you see, it's where to have this retinal detachment, you just see some flashes from one eye, but since the other eye is okay, perhaps you don't think that it's something important, and so you lose your sight from one eye. You see some sort of flashes from one eye, but the other eye, it's okay. So you can lose your vision from one eye and don't understand how severe that symptom was. So, end of neoplasms. Have a look here. If somebody becomes an ophthalmologist, you have the examination of the fundus of the eye. This is called ophthalmoscopy. Okay, now let's have a look here. You see the vessels. We have a 54-year-old woman with a deteriorating vision for 5 years, quite a long time. She has an irregular loss of visual fields on objective testing. Her hemoglobin A1C level is increased. Have you any idea if we measure this hemoglobin, this glycosylated hemoglobin? This is a specific examination, and you find it increased. Which systemic disease is the one that you think if you find this? It's diabetes, all right? So, of course, you can have the blood sugar counted after fasting, early in the morning. But a more reliable marker of diabetes is glycosylated hemospherin, because it shows the degrees of sugar, not just the day that you count the sugar, but for about a period of 3 months, how high the sugar is, because you understand that the sugar in the 24-hour of each day rises and reduces. So this is a more specific exam, a more specific test. And she had a myocardial infarction 1 year ago, most probably because diabetes causes atherosclerosis. So a coronary artery of this diabetic patient have been sclerotic, and the plaque changed, a thrombus developed, and we had infarction. That means acute blockage of the vessel, and we have the coagulative necrosis of the part of the heart which took blood from the acutely obstructed vessel. Here is the fundus, and you see here that this is a pre-proliferative diabetic retinopathy with microangiopathy, and there is edema and retinal exudates. And how do we see these exudates if you are an ophthalmologist? There are either soft microinfarcts, like here, or yellowish exudates. These two signs mean that there is a pre-proliferative, a background diabetic retinopathy. In the next case, however, we have again a middle-aged man, 6-year history of progressively worsening vision, and the past 3 months, things went worse. The fasting serum glucose is very, very high. In the morning, 200. It should be lower than 110. And here is the fundoscopic examination. Again, we have diabetes mellitus, and here is neoangiogenesis, and this is the proliferative. What do we see here? There are very small vessels that have grown, newly formed vessels, towards the vitreous humor. What is the vitreous humor? Is what the vitreous body contains. All right? That's the vitreous humor. And they are prone as being new vessels. As they are new vessels, their walls are thin. So they break very easily, and we have microhemorrhages. So you can see here the areas of hemorrhage, and these obscure vision. Again, there is a danger for retinal detachment, another cause of retinal detachment other than tumor. And we have all these cells of the vessels, endothelium, pericytes, affected by a high level of circulating glucose, and these high glucose levels lead to endothelial. These are the basic products that harm tissues in diabetic patients. Advanced glycation end products. They mainly affect vessels and make them vulnerable to break. Yes, please. The proliferative term is justified by the formation of new vessels. Yes, yes, please.
The reason for retinal detachment is increased pressure.
I'm not sure. I'm not sure that it's increased pressure. Possibly it's a matter of vascularization, because if we have hemorrhage, then the blood supply is not adequate. And to my judgment, I'm not an ophthalmologist. It's a tough lesson for me today. Anyway, nobody wanted to do it, so I took over. But most probably it's due to not enough blood supply to the retina. Next. Here we have a cytological specimen, not histology, Mears cells, exfoliative cytology. It's a very young girl with 1 month history of right eye irritation. It scratched the eye and became red. And here we have an enlarged upper tarsal conjunctival lymphoid follicles. So this is the tarsal and this is the conjunctiva, all right? There were follicles there, meaning that follicles are composed of lymphocytes. So what could be the cause of this increase of lymph follicles in this area? Perhaps an infection. It's possible. Of course, since they are lymphocytes, one could think of immune inflammation. Have you any idea, now that you have done basic immunopathology, what immune inflammation affects the conjunctiva? And also it affects the minor salivary glands at the base of the mouth. Have you any idea? No, this is infectious. This is infectious. If we are talking of an autoimmune inflammation, have you heard? And so if the conjunctiva is affected and the lacrimal gland is affected, it does not produce tears. So it becomes dry. The conjunctiva becomes dry. And similarly, the minor salivary glands on the base of the mouth are destroyed by the lymphocytic inflammation. And so you have a dry mouth as well, because they do not produce saliva. So have you heard of this disease? It's Sjögren's syndrome. This is autoimmune. Not infectious. This is an autoimmune disorder. Now let's have a look here. We have the Giemsa stain on this scrapping. That means we took cells and make a smear on a glass slide. And we see this area here. This is an intracytoplasmic. That means within the cytoplasm, an elementary body, and this is indicative of chlamydia. So chlamydia brings lymphocytes to the area. Remember that taking into account which infectious organism is responsible for the inflammation is what you expect to see to predominate in the inflammatory infiltrate. As we said, if we have some bacilli, Streptococcus, Staphylococcus, which cells should predominate in the field of inflammation? Which cells? Neutrophils. Here we have chlamydia, so neutrophils are not of major importance in facing this infection. So we have lymphocytes. Do you remember from our lessons in inflammation which other infectious agents other than chlamydia bring lymphocytes to the place of inflammation? Do you remember? They do not have neutrophils, at least as the predominant cellular population. Viruses, all right? A viral inflammation has a lymphocytic infiltrate. So does chlamydia inflammation with chlamydia. So this is called, this disease, a chronic progressive infection. That means it is not self-limited. You have to do something. It is not self-limited, it is progressive. Is trachoma, and we can have some severe complications, as you can see. And of course, we have antibiotic therapy, which is decided after this cytological diagnosis, and the risk factors are poor hygiene of the region. Here is another infectious. Do you see this? It's some sort of a cut. I'll be very happy to answer the questions, but after the lesson, because we have only a quarter and there are quite a lot to do for us, after the lesson you can tell me anything you like. You see here that this is the keratitis, and this is due to herpes. And you see it's like an ulceration. That means it's some sort of cutting of the covering cells of the conjunctiva. That's why we have this dendritic line here. And this can penetrate through the cornea to rupture the glove. So it must be treated. So we have herpetic keratitis here. You know all this. I'm sure you know. What has happened to this lens, you see? And everybody who has this disease, mainly of old age, but not only, because there are some AIDS-related lesions which appear earlier than the basic here disease. What's this? It's cataract, all right? So, a painless deterioration of vision, and here we have the opacification of the crystalline lens. This is a cataract. You see the center, which is primarily affected, and we have a gradual expansion, and everything you see becomes vague due to the cataract. So what happens there? There is a liquefaction of cortical cells, and this leads to fragmentation of lens fibers, and this is progressive, and it becomes sclerotic and brownish. You see this membrane here? Have a look here, this membrane. So, a progressively enlarging lesion of the sclera, and what we see here, this is a pterygium. This is an area of connective tissue deterioration and a damage in the connective tissue, it can form this membrane. So if it did not involve the cornea, there is another term to name this lesion. And of course, this is associated with advancing age. And what does this cause? It causes dryness, and if the area is dry, it can more easily be destroyed. The epithelial covering can be easily torn and destroyed, and there'll be an ulceration. What problems do we have here? Have a look. These areas of the field are not defined. So you have a loss in your optical field, a loss in the optical field. So this is a 64-year-old woman with hyperopia. Hyperopia is when you do that to read, all right? It's the age-related, hyperopia. Farsightedness. And she had a deteriorating vision for the last 4 years. And we have a look here, the primary angle closure glaucoma. Remember where the anterior chamber is, and what's happened here? It is normally filled with the aqueous humor. If this is not adequately reabsorbed, it stays there. And what does this cause? It causes an increase in the pressure. That's why when always you check your eyes, you have a counting of the pressure in the eye. So this is due to the diminished reabsorption of aqueous humor. And here are some agents which you can give on a therapeutic prospect, either to increase the outflow or later on to decrease the production of the aqueous humor so that the pressure is not above a permitted value. Yes, yes, please. I think yes, but in any case, you should always, it's not cured and you forget it, because perhaps it may recur. So you must have a regular check in any case, Now, here is another similar problem with the loss in these areas of the optic field. And this is again a glaucoma with increased intraocular pressure. And you have to check the angle of the anterior chamber to see if it is open angle or closed angle. The most common is open angle glaucoma. And there are also some concurrent ocular disease, a hemorrhage within the eye, uveitis, neoplasia, and they can cause lens displacement, and this can cause a secondary glaucoma. What does the term secondary mean? Secondary means that it's something which is not the initial problem, something which occurred due to another harmful situation in the eye. Here, a 44-year-old man has had a severe headache for the past day. Fever, nasal rigidity. Do you know what this is? When you try to press here, the patient cannot do that. This is a sign, in most cases, that there is some sort of meningitis. But it's not the only lesion that justifies this sign. And here is the fundoscopic view. Here is the MRI, and this is very, very serious. If you have this lesion here, what has happened? It's an edema in the papilla. What is the papilla? It's where the optic nerve grows and goes to the brain. So when we see this sign on the fundoscopy, we have a sign that intracranial pressure has increased. So this is very important because you have to find the cause of this increase in intracranial pressure. If you leave it untreated, what may happen? Due to the increase of the intracranial pressure, some parts of the brain will be compressed. And if in these parts of compressed parts of the brain there are vital neurons for the respiration and all this, it could be fatal. So this is very important to see what is related to the increase. For example, what could be related? It could be an infarct of the brain, or a tumor of the brain could cause that. All right, so it needs investigation. And this very, very serious complication is called herniation. It's what I told you, the compression of parts of the brain due to increased intracranial pressure. So in these cases, you should never perform a lumbar puncture. Why do we perform a lumbar puncture? You see, to see, for example, the liquid there in the spine and see what cells are there. And this could be related to the increase of the intracranial pressure. What cells could be there? If you see neutrophils, for example, that could be a sign of inflammation within the central neural system, or the meanings. What else could you find in this liquid? You could find malignant cells. So that could be a sign of a tumor spreading within the fluid. However, when there is a herniation that is going to come, you should not perform the lumbar puncture, because this could make things worse, and you'll make damage to the brain. So the finding here that we have the papilla edema suggests a diffuse cerebellar edema, and in this case, infection is the most probable cause of this increase. Here is Bruch's membrane. You see here the retinal pigment epithelium. Remember from histology, what are these photoreceptors called? You remember? Yes, all right. A 75-year-old woman, a 5-year history of increasing visual impairment, and what do you see when you look at the fundus of the eye? Discrete yellowish deposits in this membrane, the Bruch's membrane, and geographic atrophy of the retinal pigment epithelium. And you can see here which part is affected. This is age-related macular degeneration. And here is the macula. Remember, we saw that in the anatomy, the area of the macula, the greatest density of photoreceptors is there. And we have a central visual field distortion. So this is the atrophic form, and it has to do with some deposits. Angiogenesis occurs, and as always, these newly formed vessels are thin-walled, so they can penetrate through the Bruch membrane beneath the retinal pigment epithelium, and this likeness is responsible for these exudates. Let me show you the area from the first slide, the anatomy slide. Here we are. This is the retina, all right? This is where papilla edema is observed, and we have the other area, here it is, the macula, which is affected in the last case of the macular degeneration. So now I think we have some time. You can ask me anything you like. You wanted to ask me something. Tell me.
I don't remember the word. It was trichosis.
That's the infectious, yeah. the infectious case, yes.
With the conjunctiva.
Yes.
what does it mean, trichosis?
You remember let me find the slide. Let me find the slide. It's the one with the cytological smear. Here it is. So, this is due to Chlamydia trachomatis infection. This is trachoma, that's the cause. And eventually, what happens in trichiasis? What happens in trichiasis? We see the lid turning inward, so the eyelashes impinge on the conjunctiva and induce further trauma and scarring. So what happens? Due to the inflammation, the lid turns in. So the area is affected and it becomes prone to damage. And this can cause scarring. In very, very severe cases, this could affect the opacity of the whole cornea and be a cause of blindness. But this is too extreme for such an infection. You take the antibiotic therapy and the whole area is again comes to normal.
So there is damage to cornea because of friction, because it turns inward?
Yes, it goes inward. The eyelid here turns in.
Okay. And
Anything else? Yes, please. No.
why we can't perform lumbar puncture during increased intracranial pressure?
When you take the fluid from the lumbar spine, the pressure is increased more temporarily, but this can cause very severe damage.
Why is the pressure increased when you try to?
Because you enter something. Yes. So you won't do that. You go immediately to neurosurgery and open the skull and find the cause of the increased pressure. All right? Okay. Thank you.